Hello, and welcome to the Point of Care podcast. Today's episode features the blog post titled 6 Facts Every Clinician Needs to Know About Tumor Lysis Syndrome in 2025. Let's begin with our first key fact. Risk stratification dictates the intensity of prophylaxis, but novel agents like venetoclax have broadened the spectrum of at-risk patients. Traditionally, the highest risk for tumor lysis syndrome, or TLS, is associated with bulky, highly proliferative, and chemosensitive hematologic malignancies. Think of conditions like Burkitt's lymphoma and acute leukemias, that's ALL and AML, especially when there's a high white blood cell count, greater than 50 to 100,000, or an elevated LDH. However, the risk landscape is evolving. The introduction of highly effective targeted therapies has made TLS a significant concern in malignancies previously considered lower risk. The most notable example is the BCL2 inhibitor venetoclax, which has raised concerns in diseases like chronic lymphocytic leukemia, or CLL. Therefore, risk assessment must consider not only the disease type and tumor burden, but also the specific anti-neoplastic agent being used. The bottom line is that all patients starting systemic therapy for a hematologic malignancy require formal risk stratification to guide prophylactic measures. That brings us to our second point. The Cairo-Bishop criteria distinguish between laboratory and clinical TLS, with the latter signifying end organ damage that demands aggressive intervention. Tumor lysis syndrome is formally diagnosed and graded using the Cairo-Bishop criteria. A patient has a laboratory TLS if they exhibit 2 or more of the following metabolic abnormalities. This has to occur within a 3-day window before therapy or a 7-day window after. The criteria are a uric acid level greater than or equal to 8 milligrams per deciliter, potassium greater than or equal to 6.0 MEq per liter, phosphate greater than or equal to 4.5 milligrams per deciliter, or a corrected calcium less than or equal to 7.0 milligrams per deciliter. A 25% change from baseline for any of these also qualifies. For a diagnosis of clinical TLS, the patient must meet the criteria for laboratory TLS and exhibit at least one clinical complication. These include acute kidney injury, defined as creatinine greater than or equal to 1.5 times the upper limit of normal, seizures, or cardiac arrhythmia and sudden death. This distinction is critical. Laboratory TLS requires intensified monitoring and prophylaxis, while clinical TLS is a medical emergency that requires immediate, often ICU-level treatment. Moving on to our third fact. Aggressive intravenous hydration is the universal cornerstone of TLS prevention and management. The primary goal of hydration is to maintain high urinary output. This increases the renal excretion of uric acid, potassium, and phosphate, while also minimizing their concentration in the renal tubules. Prophylactic hydration should begin 24 to 48 hours before the initiation of chemotherapy. A typical starting regimen is isotonic saline at a rate of 2 to 3 liters per meter squared per day. The goal is to achieve a urine output of at least 80 to 100 mLs per meter squared per hour. Of course, careful monitoring of volume status is essential to prevent fluid overload. This is especially important in elderly patients or those with pre-existing cardiac or renal dysfunction. It's also worth noting that urine alkalinization with sodium bicarbonate, which was historically recommended, is no longer standard practice. It can actually worsen the precipitation of calcium phosphate crystals and has limited benefit in the era of effective hyperuricemic agents. Next, let's discuss uric acid management. Rasburicase offers rapid reduction of uric acid but is contraindicated in G6PD deficiency and requires special sample handling. While allopurinol prevents the formation of new uric acid by inhibiting xanthine oxidase, rasburicase works differently. It's a recombinant urate oxidase that rapidly metabolizes existing uric acid into highly soluble compound called allantoin. This makes it the preferred agent for high-risk patients or those with established hyperuricemia, meaning a uric acid level greater than 8 milligrams per deciliter. However, a critical byproduct of this reaction is hydrogen peroxide. In patients with a glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency, this can induce severe hemolytic anemia and methemoglobinemia. For this reason, screening for G6PD deficiency is mandatory in at-risk populations before administration. This includes individuals of African or Mediterranean descent. Furthermore, rasburicase requires special sample handling. Because the enzyme remains active outside the body, blood samples for uric acid measurement must be immediately placed on ice and sent to the lab for quick analysis. If this step is missed, the enzyme can artificially lower the uric acid level in the tube, leading to a falsely reassuring result. Now for our fifth point, which highlights a shift in modern practice. In modern practice, hyperphosphatemia has overtaken hyperuricemia as a primary driver of acute kidney injury in TLS. With the widespread and effective use of rasburicase, uric acid nephropathy is now a less common cause of renal failure in TLS. Today, the metabolic derangement of greatest concern for the kidneys is severe hyperphosphatemia. High levels of serum phosphate bind with calcium, forming calcium phosphate crystals. These crystals precipitate within the renal tubules, leading to obstructive nephropathy and acute kidney injury. This process is made worse by a more alkaline urine pH. The resulting hypocalcemia can cause neuromuscular irritability like tetany and paresthesias, as well as cardiac arrhythmias such as QT prolongation. Management involves aggressive hydration, phosphate binders, and frequently renal replacement therapy. It's crucial to only replete calcium if the patient is symptomatic, for example, experiencing tetany or seizures. Administering calcium in the setting of hyperphosphatemia can worsen renal precipitation. Finally, let's cover the most urgent threat. Hyperkalemia is the most immediately life-threatening electrolyte abnormality in TLS and requires urgent management to prevent fatal arrhythmias. The massive and rapid release of intracellular potassium can overwhelm the kidney's ability to excrete it, leading to severe hyperkalemia. This is an emergency. It can cause peaked T waves, QRS widening, and ultimately ventricular fibrillation or asystole.
Any patient with TLS and a potassium level greater than 6.5 milliequivalents per liter or any EKG changes requires immediate intervention. The management follows a three-pronged approach. First, stabilize the cardiac membrane with intravenous calcium gluconate or calcium chloride. Second, shift potassium intracellularly. This can be done using insulin with dextrose and/or nebulized beta agonists like albuterol. And third, remove potassium from the body. This is achieved with loop diuretics if renal function is preserved, potassium binders like patoromer or sodium zirconium cyclosilicate, and emergent hemodialysis. Hemodialysis is the most definitive therapy for severe or refractory cases. That's all for this episode. Thank you for listening to the Point of Care podcast.